What happens when the very system meant to protect doctors end up driving them away? In New South Wales, junior doctors are paid up to 30% less than their colleagues interstate. Intern spots are going unfilled, and senior specialists are resigning in protest. The result is a public health system on the brink, where burnout, moral injury, and unsafe staffing are becoming the norm.
In health, the stakes are incredibly high. The expectations for failure or errors are incredibly low. The resourcing is challenged. Your reputation precedes you through your career, and that makes us vulnerable. There's a notion in health, which is the duty of care, and we sometimes use that to say, oh, this is my duty of care, and we use that to motivate and encourage. Sometimes that's used against us to say, it is your duty of care. The duty of care is actually so profound in health that we need to have medical indemnity.
In this episode, I'm joined by Dr. Nick Spooner, emergency physician and president of ASMOF New South Wales, to unpack what's really happening with the enterprise bargaining agreement, why the award system is so outdated, and what it means for the future of doctors, patients, and the survival of our public healthcare system in New South Wales.
The system will take all that you are willing to give.
Yeah, and if you have someone who's willing to take everything you're willing to give until the end, you've got nothing left to give, then what happens?
Here's what we'll cover: why New South Wales is struggling to attract and retain doctors compared to other states, how outdated awards are pushing specialists towards locuming and VMO work, and what that means for teaching, training, and patient safety. And lastly, the real stakes of industrial action when lives are literally on the line. This episode will give you clarity on how these changes could affect your career, your training, and the patients you care for. Now let's get into it.
Welcome to a special episode of the Investing for Doctor podcast. Today, we're not really going to be talking about investing or finances, but we'll talk about an episode a bit more dear to our hearts, our collective hearts at that. We're talking about the enterprise bargaining agreements that's happening within New South Wales Health. And by extension, this could apply to members across Australia and doctors, junior doctors, consultants, and everyone involved in the medical profession. So today I've got here a special guest, Dr. Nicholas Spooner, and he's the president of ASMOF New South Wales.
You got it. Yeah, correct. Thanks,
all right.
B, for having me.
No problem. I'm going to call you Nick because I've known you for a very long time. And so Nick, tell us who you are, where you come from, and your journey in getting to where you are today.
Certainly. Well, as you can probably tell, or will in short order be able to tell, that my accent is not Australian. I'm from Canada. Mm-hmm. In a previous life, I was an aerospace engineer in Canada, and then did a master's in biomedical engineering and developed a fondness for medicine. So I arrived in Australia the end of 2006, beginning of 2007, finished my degree at Sydney Uni, and
that's where we met.
And that's where we met.
Yeah.
And I have been an exclusive product of New South Wales Health for my entire medical career.
Yeah. So you obviously have, gone through that whole journey from medical school, internship, residency, all of that until who you are today. So give us a bit of background, what specialty are you and, where you work?
Yeah, so I'm an emergency physician. I work on the Central Coast, just north of Sydney. I am the director for the emergency department at Wyong Hospital. And prior to that, I was the deputy director for the emergency there. I have also worked as a registrar and a specialist around John Hunter area, doing some retrieval at times, as well as intermittent locums across the state.
Yeah. So we both practice in emergency medicine, slightly differently because you're FACEM and I'm just a regular CMO. But, we both also locumed across New South Wales and have seen probably a fair share of the number of hospitals. I think I have a little bit bit better than you because I spent 2 years in Melbourne. And so I get to actually see how it's slightly different in a different state and how it all works. For those that have never worked in New South Wales, why don't you give us a brief rundown of what the problem is right now and why it's such a huge problem for the profession in New South Wales? Tell me, Nick, how did you end up becoming a director of a emergency department to becoming a head of our union?
Yeah. Well, it was an interesting journey. And what I found was that whilst I was trying to advocate for resourcing, workforce resourcing for our department, we were, experience workforce shortfalls, and we can go into some of the nature of that later on. But they were certainly challenging for delivery of patient care, as well as the morale for staff. And I found that the barriers to workforce challenges were not at the workforce level. They weren't at the level of the directors of medical services. The barriers weren't necessarily the chief executives of the districts. The barriers were often quoted or claimed to, when I was naive to the process, they were claimed to be related to the award for New South Wales. And rather than sort of continue to bang my head against a brick wall of the, executive directors for the district and the directors of medical services, I started to explore where you would lobby and where you would advocate if truly the barriers were the award, where you would do that. That seemed like sort of the rational, logical thing to do. And I found myself on a journey that ended me up applying for the position of the president for the Union for New South Wales, and have since been doing that position for the last several months.
Yeah, awesome. And so now that you've taken up this position, what have you learned from this, the last couple of months? And, it's obviously a challenging time to be taking on this role, because I think both the junior doctors, staff specialists are all up for negotiation. And I'm quite sure the VMOs are also having their separate, issues right now and undergoing negotiation for them.
Correct. So to remain positive, I try to break down my experience into a personal experience, my professional experience, and my industrial experience. My personal experience has been that this is, a fascinating realm, and a really rewarding realm to be involved in, to have all of these experiences. And I value all of them and all the people that I get to meet and interact with. From a professional perspective, it has been tremendously busy. Department director, family life, kids and school and all of those things, as well as the union activities. Purely from an industrial perspective, the journey that we have been on of late has been terribly frustrating. Yeah,
I can imagine. So I have worked in sort of two different states, and I'll share a bit on my personal experience, and you can probably comment on that. I remember, like yourself, I was an international student, back in the days in a senior uni. And I remember even back then there were issues with, jobs. We weren't guaranteed a job. So, for those that don't remember, I still remember it vividly because I was quite vocal about it back in those days, as the vice president of our medical society. It was, I think, the only people we were placed above were international students that did their medical school elsewhere. So if you were, and I have nothing against New Zealanders, if you were a New Zealand, citizen and you did your medical school in anywhere in the world, you would have gotten a job before our locally trained international students. And that, at that stage, sounded like a bit of a fast to me. But anyway, I got a job in Victoria. So I worked at Monash, and I also worked another year in, Alfred before I had to come back because we got family ties and that sort of thing. And, I took a massive pay cut to come back, even though I went from, being a second year to a third year. And, what I experienced then was that we had a massive cut in our salary packaging entitlements, because in Victoria, we got everything back. Whereas in New South Wales, we had to pay a administrative fee, to New South Wales Health for the privilege of that. So, right. I think from memory, way back when that was a thing, it was sort of like, okay, we have to do this to give you guys a pay rise, but now our pay is even worse than everyone else. So, what's happened there from your side?
Well, I think the first thing we should probably touch on is the nature of the workforce shortage. And you've highlighted an interesting dilemma, even from the graduation from medical school, which was that you sought employment elsewhere outside of the state. There is a workforce shortage, both in the quantum, in the number of doctors, as well as in the distribution of doctors across the country.
So let's go on a journey, because obviously everyone who finishes medical school, they start off as an intern, and the award is not just a quantum of dollar and cents perspective. It's also the way that the doctors are classified and stratified and the levels that exist, right? So, from the get-go, if you chose to do your internship in New South Wales, you're basically being paid, 25-30% less than a counterpart, say, in Queensland, for instance, use our northern neighbors, and something a bit less, than, maybe 20% less than if you were in Victoria. And so those are, the two other biggest competitors, for New South Wales for staff.
Yeah, absolutely. Yeah. And certainly there is something to be said about the quantum or the numbers in terms of
like
remuneration.
Wage. Yeah, like an hourly
wage.
Yeah. There's more than that, isn't it?
There is more than that. And I would use if I could use a footy analogy. If we're a footy team and we go to play and we have 2/3 or a third less the staff as the other team.
Or a salary cap, which is 2/3 of
or a salary cap, or some other attraction and retention aspects of the way that you're valued that is disparate from another team, and you try to play short-staffed or without the adequate number of players. When you play, and then subsequently when you lose, and that's a rhetorical question because you clearly lose, and you reflect on what's just transpired, and you look at the field next to you, and there's a full bench with a team and a coach and a clubhouse and a physio and all of those other aspects that are fundamental to performance. Where are you going to play next year? Who are you going to play for next year?
Yeah, the other thing.
And again, that's what we're faced with in New South Wales. And there are many aspects to that. And we should probably explore some of the interesting nuances about public health, some of the nuances about doctors themselves, and perhaps the system. If we were going to talk about public health, we are progressive in this country and have said that health should be public. And we should, prioritize that, and it should be funded through the Commonwealth and through the state. Because we're so progressive, we've said that it's so fundamentally important, which is good. And I personally feel that that's an appropriate thing to do.
Yeah.
It's so fundamentally important that, in fact, the Industrial Relations Commission can order fines, and the government can seek orders from Industrial Relations Commission against the union if we were to threaten or propose industrial action that would affect healthcare, because it's so fundamentally important. So that's an interesting nuance about public health. The other nuance about public health, and it's probably most jobs in particular, or most jobs, is that the system will take all that you are willing to give.
Yeah.
In fact, we asked if we could.
We see that. Yeah.
Yeah. We asked if we could include safe working hours, a notion about safe working hours in a new draft of the award. And that was essentially knocked back by the ministry. We know that any organization, unless there are things put in place to protect the workers are capable of giving all they can give. If we talk about the workers for a minute, the nature of the people who choose health is probably a pretty unique subset of people.
Yeah, it's people who, most people go into it because they like caring for people. They want to help people. And, the odd person wants to go in for personal and selfish reasons. But by and large, most of us have a degree of altruism.
Exactly.
Yeah. And I get what your point is, that if you have someone who's willing to take everything you're willing to give, and then it says give.
Yep.
Until the end, you've got nothing left to give, then what happens?
You're right. And so we have the nature of the workforce. In health, they have a certain moral compass, and they want to look after the most vulnerable and the people who are suffering. And we get a reward for that. We're able to help, and we get a little dopamine from being able to help people in their time of need. There is also a subset of people who stick around in the public system. So there are other options in health. We have a hybrid system in Australia that allows us to offer both public and private health. And the people who stick around, especially in public health, are an even more unique breed of people, which, and I'll come to later, which perhaps makes them also even more vulnerable than health employees in general. The people who stay in public health, perhaps even more vulnerable because of that.
I see that. I mean, I do a bit of hybrid and everything. Yeah. And, to be very honest, if I did something privately, I'll easily make double the money.
Yeah.
But I like staying in the public system because they're family and you really get to help people who actually are in need. And, I think that's something that's very rewarding. But at the same time, that needs to also be non-detrimental to yourself, to your value, your worth. And, we both have families. We got families to feed, mouth to children to raise. And, children are not cheap these days. So.
Yeah, no.
But back to your point.
So we have a maldistribution of workforce. We have a vulnerable population of workforce in a system that's willing to take everything you could give. If we talk about some of the system aspects for the minute, in health, the stakes are incredibly high. The expectations for failure or errors are incredibly low.
Yeah.
The resourcing is challenged.
Yeah.
Stress leak is a real commodity. Your reputation precedes you through your career. And again, that makes us vulnerable. There's a notion in health, which is the duty of care.
Yeah.
And we sometimes use that to say, oh, this is my duty of care. And we use that to motivate and encourage. And sometimes that's used against us to say, it is your duty of care to do something.
Yeah. But then where's the duty for the employer or the system to not abuse that?
Well, exactly. So the duty of care is actually so profound in health that we need to have medical indemnity. There are, if you're running a small business, you should have insurance. There aren't many occupations where indemnification for you personally is a necessity. That's because the stakes are so high and the expectations are so high and the appetite for failure is so low.
Yeah. Use an example, right? Because like if you're an accountant, you gave a doctor, the wrong advice and they get slapped with a fine. The accountant loses a client. Nobody dies. Yeah. We screw up. Sometimes somebody dies or mangled or whatever. Yeah. So I guess, that's the point. And even, and we're comparing with other professions as well.
Yep.
If they happen to lose a client, what are they going to do? Come back and sue you for that? I mean, not really. When you sign off on your tax return, every time you do it, there's like, I indemnify the accountant for anything because I had to check it through. But you don't know anything. So it's like, if I was, if we were flipping it around in medicine and I go to patients, like, okay, I'm recommending this, but anything goes wrong, like, I'm not responsible. I mean, that doesn't work, right? It's clearly not the case.
Yeah, you're right. And some of that is because of the moral compass for the clinicians who choose to pursue this path. And some of it is the system, which has, the systemic expectations.
Yeah.
We have a limited workforce, a vulnerable workforce, and a system that's happy to take everything you're willing to give.
Yeah.
It's like essentially the perfect storm for clinicians and patients to potentially be at risk.
Yeah. And I think a lot of this also comes down to just simply numbers, staffing, right? You can't get staffing. You can't run a decent service, but then all of these other stressors and things in the background are still there. They don't go away.
No.
Right? The ambulances don't stop coming. And so what do? You work harder and sometimes you have to take on additional risk, putting patients in who should be monitored into non-monitored areas or, offloading them into a chair rather than a bed space and all these sort of follow-on consequences of that. But again, it still comes down to the fact is that we don't have enough people. And one of the reasons is that they're not being paid enough. They're not being looked after and they are working harder than everyone else, who could be working the same role in a different system. So, like let's take nursing, for example. In Victoria, nursings have nursing ratios. So they have a limited number of patients they have to look after. That doesn't exist in New South Wales, right? And so you could be looking after 6 patients. You could be asked to look after 8 patients. And if someone calls in sick, you may be looked after a lot more. And that's where things go wrong, I guess.
Certainly in New South Wales, from a nursing perspective, we we do have ratios.
Yeah.
Totally
Yeah.
right.
I mean, I should say, EDs in critical areas, we have ratios. You know, if someone's intubated, you need to have one nurse there at all times. But like on the wards, that's a completely different story.
But what we do see in emergency departments that are overwhelmed is that the ratios for bed spaces, clinical bed spaces, may be okay. But if you have ambulance ramping or you have people in waiting room chairs, those are not often accounted for in ratios.
So, as I previously said, as an intern, you're paid less, than, someone in Victoria or, pretty much we're the lowest paying state of the whole country, right? So unless you really had a reason to be in New South Wales, such as family or ties you can't do, most people would just bail, wouldn't they? They would just go to a different state.
And that's what we have been seeing.
Yeah.
You, as you said, early on in your career, if you haven't got family, partner, spouse, kids, dog, a mortgage, you are much more capable of perhaps relocating somewhere else.
Yeah.
And we have seen, at least for a few years, that the number of medical students being produced in New South Wales has not been enough to supply all the spots in internship years.
Yeah, that's funny because I remember many years ago, I mean, this was in our time, there weren't enough spots to go around and they had to bat people away. And I think it was only the Commonwealth supported places that actually had guaranteed jobs in New South Wales.
Yeah, correct.
So has it gone the other way now that there's intern spots left unfilled?
Yeah, correct. So,
okay.
So we, again, and then that's a nature of the quantity and the distribution of the workforce has become more and more challenging.
So that's interesting because there's, the last time I checked, there's actually more and more medical student places. But it sounds like they are not converting to internship because they're going somewhere else.
Yeah. Or
if you were thinking logically.
Yeah. Or just not adequate supply for the demand.
Yeah. And obviously the supply has different reasons for not having adequate supply. I mean, you got to produce the medical students, or previously you had other medical students coming from interstate coming to New South Wales. But that seems to have gone the other direction. And from memory, like even back in our days, 15 years ago now, New South Wales was actually quite well paid compared to some of the other states. But it feels like all of them have gone further and we've been stagnant. Correct. Is that what the numbers show?
Yeah, that's right. So the nature of the stagnation is multifactorial. One of the most prevalent issues has been what was otherwise imposed as the wage cap from the previous state Liberal government. The now sitting Labor government petitioned and lobbied to be elected based on the abolishment of the wages cap. And what we have now come to appreciate is that the wages cap has been replaced with a different policy, the fair pay and bargaining policy, which essentially says that if you aren't able to demonstrate efficiency gains in the way that you will operate your department, the government would be unable to give you more funding or pay you more.
Okay.
And that means for a system that is constrained by the paradigm we talked about from a workforce and moral compass and public health point of view, we have slowly been chewing away at all the fat in the system. There are likely no efficiency gains to be found. Whilst,
do you think that they're using that as a bargaining chip?
Well, they're using that policy. They're correct. They're using that policy to say the policy says if you can't find efficiency gains, we couldn't value you anymore.
Right. And has that applied to any of the other unions? I mean, I know train drivers that are having problems with the government.
Yeah.
Are trains being more efficient and more on time, or
that's a good question.
More passengers going through to?
Yeah, that's a good question. I don't know the answer to that question. But that is a universal New South Wales government policy that has essentially replaced the wages cap with a policy that said if you could be more efficient, we could potentially offset those efficiency gains in terms of a way to remunerate you. Okay. The issue that we then face is that actually the workforce hasn't been looking to demonstrate efficiency gains. We are in a position where we need to make a work value or a wage claim about the different ways that we work now as compared to when the award was drafted and instated. And because it has slowly eroded over time, again, because of the paradigm of a vulnerable population who wants to do good by the patients and moral compass stuff, we find that we have a fair ways to go in order to be with parity to other states.
Yeah. So I guess the one of the major problems, I mean, that's all very technical thing, but as an intern resident, who's choosing where to go undertake their further training, it's vitally important that they feel valued and, from start to when they finish, right? Because like the way I see it is that if you're a junior doctor and you're decent at what you do, and you have no connections to New South Wales, you're going to get out of here.
You could go anywhere.
You can go anywhere, right? You can go somewhere where you're valued. You can go somewhere where you're paid.
Yeah.
And from the last time I actually looked at the awards across all the states, from we'll talk about junior doctors first, and then we'll talk about the staff specialists. Is that there's a couple of issues that junior doctors are suffering because it's a quantum amount, and that they're getting paid less per hour. Their leave entitlements are sometimes less. They don't get the extra teaching, and study leave allowances to allow them to get to the next step. So you end up falling behind with all of the other, trainees from other states because you don't get that, either paid time or, allowance to actually undertake further education and studying because, medicine's obviously a lifelong studying process. Then they fall seriously behind. And then you throw in the added workload because we're probably grossly understaffed anyway, then it becomes a very terrible sort of position to be in. I remember back in the days when we looked at, let's say, the physicians trainees, they'll say, okay, these hospitals have decent workload and the pass rates are high, so we're all going to go to those hospitals, right? Yeah. Whereas, the hospitals that had poorer numbers tend to suffer, and then that becomes a vicious cycle.
Yep, you're right.
Because then they get the lesser trainees, and then they have to work harder to compensate for all of these things.
Totally. And we see that in terms of an institution or a district or something getting a bit of a reputation to say, actually, that it's hard work there. And it takes years to fix that. To fix that and to get out of that.
And it takes some special kind of people to say, okay, you know what? I like a challenge.
Totally.
I'm not going to work in a cruisy place.
Totally.
Yeah.
The other interesting challenge for junior doctors especially is that in New South Wales Health practically is the only employer that with whom they could train.
Yeah.
And so essentially they have a monopoly on all junior doctors.
Yes.
And that means that if what they're offering
is crap,
if it is crap, as compared to other states or other options, they may not choose to stick around, or they may be compelled to stay because of their family family things or other ties, but they may feel, possibly disenfranchised, resentful, leads to, moral injury and burnout and all of that, which ultimately is poor for...
It's detrimental to the whole system, the profession and everything, right?
Yeah.
And I guess one of the other things is that I want to point out why the award in New South Wales is so antiquated is that I think the registrar grade only goes up to 5 levels.
Yeah.
So, what that means is that if you're taking additional years, which a lot of people are doing now, you don't progress. You basically cap at inflation, or below inflation, which is what's happening right now.
Yeah, correct.
Whereas other states, I think Queensland goes up to 10 levels. So, the more senior you are, it goes up beyond that sort of inflationary or award-based increases, right?
Which would be natural evolutions when those things were pointed out for them to sort of be addressed and for the award to morph and change and evolve.
Yeah. So it's antiquated.
Correct.
Yeah, it's antiquated because back in the days, they were like, okay, you do your intern year, you do your resident year, you get on a training program, you do 5 years, and then you're a consultant and maybe you screwed up 1 year in between or took your time and it took you 8 years. But now easily it's becoming 10 years, 12 years. And that's horrendous. And it's even worse for our female colleagues who take additional breaks to have kids. They choose to have that. And I think, I'm seeing a lot from the junior side because I work amongst them because I'm technically one of them. But... it's, that's what I'm seeing. And again, it's very difficult for them to step out because there's no other choice in New South Wales.
And you've pointed out again the stuff, and you pointed out in and of yourself that when you returned to New South Wales from Victoria, that you took a drop in pay, and that would be very hard for people to try to return to New South Wales with a salary sacrifice, as well as, if we were going to get more into the granular, as well as the cost of living in New South Wales.
Yeah, I mean, this is all,
So if we were going to go there, cost of living.
Yeah, that's a whole different, conversation.
Yeah,
but the cost of living in Sydney, everyone knows, is expensive.
Well, and you've pointed that out. You said, sure, New South Wales has the Harbour Bridge and Bondi Beach.
Yeah.
But
no one
what about the doctors, who are working in Dubbo or who are working on the Central Coast, or, that isn't a draw card necessarily for them.
Yeah.
And so the cost of living is also a barrier to attraction. Retention is another conversation about people who must stick around for whatever reasons. But if we're talking about how do we attract, if there is a supply and a distribution problem, if we're trying to address a distribution problem, then we're expecting people to come back from somewhere else. And so there are many hurdles to overcome there. As well.
Yeah. I can definitely see that. And I think one of the other issues that if you're on call for a hospital, you technically need to live within half an hour. And if you're working at one of the inner city hospitals, rent gets expensive.
Oh yeah.
It gets very expensive. And if you're on call, it's very difficult to still have, live in share houses and all that sort of thing. And to be honest, if you're in your late 20s and 30s, you're a professional, you shouldn't be working in share houses. You know what I mean? So yeah, it's hard.
From the union perspective, at the transition of government, we were under the impression that we were going to engage in mutual gains bargaining with the government to try to improve the conditions, working conditions, and attraction and retention for the salaried doctors as well as the patients for New South Wales.
Can I ask you, for those that don't understand, what is mutual gains?
Super. I'm glad you asked.
Yeah.
I'll give you maybe one or two analogies that I've plagiarized from previous people, but they work well in the situation.
Yeah, sure.
So mutual gains bargaining. Let's say an example is that you and I were going to share an apple, and I knew that you wanted to plant the apple seeds, and you knew that I wanted to eat it. Knowing that, we would probably split it in a different way.
Yeah.
Than if we didn't know any of that information.
Right.
Okay.
So like, I don't care about eating apple, so you can have it, and once you're done, give me the seeds and I can go plant it.
Yeah, or
just don't swallow the seeds.
Correct, or core it, or whatever.
Yeah, of course. Yeah.
So the notion of mutual gains is to share what you value.
Yeah.
And then if the sides value things differently, then you could perhaps maximize one value for one side and one value for another side.
Yeah.
And I have other examples that we could go through about that.
So it's not always dollar and cents, obviously, in that description, because of the apple analogy. Yeah. If it was about apples and pears, you just cut it halfway, and then I get half the seeds, and you get half the apple.
Yeah.
Yeah.
Which is excellent. Mutual gains is excellent when two groups are trying to collaborate to solve a problem. If I need a new roof on my house and someone wants to put it on my house, and we want to have a conversation about when can it be done, and what ones have you done before, and what does your work look like, and how much. One of the conversations can be about how much it costs, but other conversations, other aspects of what may be important to each of them is different. The issue with the mutual gains is that most of the literature suggests that it isn't very well suited to wage claim, and that's what we, at the request of the government, tried to engage in.
Okay.
And the government was very constrained in what they were able to offer. At essentially every turn, they said our initial offer is the final offer.
Yeah.
And if there is no flexibility in that, then we actually can't participate in mutual gains bargaining.
Okay.
You can't really participate in bargaining.
Yeah.
If you don't have the latitude to bargain, then is it really bargaining?
Yeah. Because, I mean, what are they putting on the table? It's, 10.5%? Is that right?
Yeah. Correct.
Yeah. Over
the 3 years.
Over 3 years.
And some of that, some of the fraction was mandated in terms of super. And depending on how you skin that cat, it certainly looks like it may be at or below inflation is possible.
Yeah. Well, I mean, that's definitely below inflation just based on the inflation figures from the last couple of years.
Yeah.
Everyone's feeling it.
So if you break that down to the even more granular is in the challenging workspace that we've discussed earlier, if someone asked you to do even more for less, how would you feel? And that's a rhetorical question.
Yeah. I'll tell them
Yeah.
Stick it where it don't shine.
So we went through the bargaining process. We invested hundreds of member and counselor hours in that process, and we had essentially very little, if anything, to show for that.
So have they moved on anything?
They have walked away from the table. They said, we don't want to bargain anymore.
Okay. So essentially we spent all this time bargaining with them, and it was initial offers, final offer. We're not going to talk about any of the other things.
Yep.
Okay. So there's really nothing to bargain then. Yeah.
That was what our experience was. The other interesting nuance was, perhaps you have heard, or some of the listeners may have heard about the Sydney Kids Hospital anaesthetists and an intensivist discussion in about 2022 with the Industrial Relations Commission. So around that time, the anaesthetists and intensivists essentially said, look, if we're working after hours and keeping a kid on the table after midnight and doing this extra work, the award has no capacity to remunerate us for the hours that we're being paid.
Let's talk about that, because I think we talked about the junior doctors now, because what's on the table is also the staff specialist contract, and I think for those outside of New South Wales listening in, or those that are on their pathway to become consultant.
Yeah. And you probably spend more of your career as a specialist than you do as a junior doctor.
Absolutely. But
we need to look after both.
Yeah, exactly. And I guess the original history of ASMOF was really from the staff specialist perspective, but then thankfully now it's reached out to everyone, because I believe junior doctors used to be under the purview of a different union, which shall not be named, that really didn't do much for us at all. And so now with the staff specialist contracts in New South Wales, for those that don't know, it's this, usually it's obviously it's an employment contract. There's really no overtime. There's no weekend loading. There's no after hour loading. There's none of that. So it's a fixed salary.
Correct. Which represented the old ways of working, where there may be, fellows in the hospital, and perhaps you took one or two calls and there was no expectation or even technology to allow you to look at a medical record off-site or to review someone remotely. None of that existed. And the new models of care and the new modern ways of working in the health system are considerably different now. Yeah, of course. As well as the numbers are going through. If we come back to the industrial relation evolution from 2022 as it relates to the intensivists and anaesthetists at Sydney Kids, they essentially tried to articulate that the award they were working under wasn't fit for purpose of the work that they were doing. And if I could try to summarize, the Industrial Relations Commission agreed, but the Industrial Relations Commission suggested that, one, if they sided with the clinicians, they would put the government in an impossible financial position. And two, they knew that award negotiations were upcoming in the next year or two. And they essentially said, go away and sort it out during negotiation and bargaining for the award.
Okay. So can I ask a very pointed question then? Is this like, what is our job for the government to fix their own budget? Are we taking on too much?
We probably are taking on what is necessary for patient care and patient safety and what feels right to us. And that's why we're doing it. But we don't have a mechanism or a technology or a way for that to be remunerated and valued. But we know that it's right.
Yeah, of course. But going back to that.
But we do it anyways.
Yeah, going back to the excuse about the Industrial Relations Committee said, we put the government in an impossible situation. I mean, the governments run a deficit all the time, and then they find ways to fix them, right? I mean, look at the Victorian government. They've had a massive deficit, and so, they're increasing taxes. That's what a government does. They balance tax receipts and spend it on the people based on the right balance. And
that may be unpopular, and it may jeopardize re-election.
Yeah. But again, that is not our problem. I think equally, if the public realizes how much of a shambles New South Wales Health is in right now, they might not get re-elected anyway. So
that is entirely possible. Even more frustrating evolution through the award negotiation was that the IRC from 2022 said this award, the draft that was submitted by Health, wasn't fit for purpose. It said go away and sort it out during negotiation.
Yeah.
Negotiation is now essentially
and then they got the same thing, and
they filed the same award that previously the commission said wasn't fit for purpose and didn't solve the problems. They filed the same one.
What's their game plan? I mean, if you were a guessing man, what's their game plan?
Well, I can tell you, and let's do the thought experiment together. I can tell you what I feel would happen. And the feedback from the award, from all members and anybody who's looked at it, says that wouldn't value me in the way that I feel I should be. And what that means for public health is that otherwise logical, rational, workforce would look at the other options through which they could be valued or paid or employed. And to summarize it, essentially, I expect that most people would say, I'm not going to work under that award anymore, and would just transition to VMO work or locum work. And that would subsequently mean, from a medium to long-term point of view, would be that all the pillars of clinical governance.
It's horrible.
So all teaching, training, quality assurance, quality improvement, M&M, clinical practice committee, quality in business, all of the things that we know are the pillars of public health that allow us to train and teach the next generation of doctors. All collapse because the visiting medical workforce is not routinely invested. They do not routinely. They're not routinely engaged to do clinical governance.
Because they don't get paid for it. Why would you?
Correct.
So I guess for the others who have don't understand what a VMO is, they're essentially like a contractor, aren't they? And on a VMO contract to do clinical work. So you're a VMO, you're either paid by what we call a sessional VMO. So you get paid by, say, okay, you do this clinic from this time to this time and you get paid an hourly rate of this much. That's one model. There's also what we call the fee for service. So if you did a clinic, then you get X amount of billing from the clinic, which comes through Medicare. And that's another whole controversy that we're not going to go into right now. But, and then there's obviously the procedural list. So if you do an operation, you get X amount of money per operation based on, Medicare fees.
That's right.
Which, by and large tend to favor proceduralists. So a lot of proceduralists are in VMOs. A lot of sort of, physicians or non-proceduralists tend to be on staff specialist contracts. And, in emergency medicine, there's a mixture of both because you're really, it's either hourly wage or you're staff specialist and you're an employee. And by and large, they're not too terribly different. It just depends the style of work you want to do. And
correct. And it also depends on what is necessary to deliver the service you're trying to deliver. And having a mix of both and a hybrid of both means that you can adapt to different expectations and different needs. The issue is if we become so disparate with the award for salaried staff and the VMO remuneration, then people will naturally transition, and that transition essentially prescribes the extinction of public health.
Because, in your staff specialist role, you have administrative time for teaching, for running a department and doing all those meetings. Whereas, sometimes the VMOs do get included in them, but that's an opt-in thing. And unfortunately, I gotta say that's an opt-in at their own costs kind of thing as well. So, cause they're not getting paid for those meetings that attend, training of registrars and all that sort of thing.
Again, the clinical governance is so important,
of course,
to public health that actually there is a whole college devoted to medical administration. So it seems to me irrational that we would prescribe a topography of remuneration that would lead to an exclusively or predominantly one-sided model, which would mean that all the pillars of public health and clinical governance would be absent.
So I guess what's happening, it sounds like, is that, the staff specialists are basically the backbone of the public system. They teach the next generation. They make sure the department runs well, deals with budget and all that sort of thing. And VMOs are the guys you get in to do certain X amount of work when it's needed. And perhaps because they also engage in private practice, so they don't want to have as much buy-in, but then they still provide a valuable resource, a human resource, to the department.
Yep.
And that seems to work well until one side gets
becomes more attractive.
Disproportionately attractive or unattractive.
Correct. Correct.
And so you end up in a situation being like, do I sacrifice the things I love with clinical government, supervising registrars, so that I can get paid more and get that house? That's a very hard choice to make, isn't it?
Yeah. And although the choice becomes easier the farther apart those two entities are.
Yeah. And we're getting to that breaking point,
correct.
aren't we? Yeah.
Exactly.
Yeah.
And especially if we, as the union and the members and the rest of the employees for public health, if we were silent and didn't demonstrate the threat that award, draft award, represents.
That's very carefully worded. I would say if we didn't fight back and against the destruction of the public health system in a way.
Yeah. You're entirely right. And so if we didn't oppose what we felt strongly was going to be the extinction of public health, then, where would we be in 5 or 10 years?
Yeah.
Where would we be both for your own, personal and your family's health and the patients you look after, but also from a professional point of view? If you're not opposing what would be the eradication of something that's so progressive, as we talked about at the very beginning. It's so progressive.
Yeah.
It's so progressive that the IRC can institute orders and fine the union if we were going to jeopardize the way that it works. But by writing an award that jeopardizes the way the public health system will be delivered, it's really fascinating.
Yeah. Okay, that's very interesting. So now that negotiations have broken down, it's obviously time for action.
Yeah.
And I guess when we're talking about industrial action, a lot of people just think about, we just walk out and strike, right? But as you mentioned, because we work in such a critical sort of part of the system, we can't just say, okay, we're all going to put our stethoscopes down and then we're going to go walk in a park and hold our race cards, because people will literally die one day.
So that is also one of the challenges about the paradigm that public health employees find themselves in, is that the service they deliver is so important and so critical, and the reason they're there is because morally they feel it's so valuable that invoking or deploying industrial activity feels so foreign to them that we are essentially that frog in the boiling pot of water. And just let it get worse and worse and worse. And I know that analogy's been debunked, but it's a good analogy.
So this has gotten so horrible now that people are willing to do the unspeakable, I think.
So and that may not be everyone, and different districts and different locations,
of course,
and different craft groups will feel differently. And it would be naive not to appreciate that. We need to have a nuanced approach so that as many people who understand the threat that the draft award that's been submitted poses are able to use their collective voices to try to evoke change.
So there's just so many facets to the breakdown of industrial relations, I guess. And I'm going to put it in, maybe a point by point form, and you tell me whether I'm completely off or I'm on the money, right? Okay. Firstly, there is a wage issue. We're being underpaid. And that's probably the easiest thing to see and the easiest for people to understand. Right. The second part is because of the wage disparity, recruitment is a major problem. And we see some evidence of that in our junior workforce, in that we're not filling internship positions, because people are not coming to New South Wales anymore.
And senior positions and rural and remote and regional.
And then, and because there is isn't really much of a rural loading or incentive to go rurally. Nobody's going rurally. So the people who only go rural are people who have family or some deep connection to those areas, or they want a particular lifestyle because they want a big house and a big yard, or they like, I don't know, horses or something. There are people who like that.
Yeah, correct.
But by and large, that's not the majority of people.
That's right.
And so we're seeing a crisis in rural health as well. And in some places where we're on the outer Sydney, like the Central Coast, it's nice to be there, but like it's not as central as, some other people would like to live. So you tend to have the effects of being not central.
Correct.
And that's probably been felt in your department. And, likewise in Western Sydney where, I do some work at, it's also seen as a less sort of desirable side because it's hugely busy and it's understaffed, and there's too many patients. And so those places also, starting to get hit more and more, whereas the inner city hospitals are still doing quite well because they're well funded. They've got lots of people who want to go there, so they don't really have much of a staffing problem. But it feels like the water is boiling from the periphery, and slowly in and out, to use the frog analogy.
Yeah, you're right. Yeah. And I guess the one challenge so there is certainly a metro and rural disproportion of workforce distribution. The one challenge that the metro centers face is just the sheer quantum of patients, and the size of the buildings, and are they able to find enough space to look after the patients?
And I think that is definitely happening. But then we are building all these new buildings and then decommissioning the old buildings, and at the same time either cutting beds or keeping the same amount of beds, which is just insane. Population is growing. Our bed space have not really grown in New South Wales.
Don't quote me on it, but I think in fact, if you look at hospital beds per capita, I think it's actually it's full.
Oh yeah, it's gone down. It's definitely gone down. Because when you have more people and your beds haven't increased, per capita is going to go down, right? And the worst of it is felt in the growth centers because they're where all the high rises are going. For instance, I know Concord for a period of time when the entire Wentworthville area came up, opposite roads. All of those high rises came up. They got massively hit by the influx of patients. I remember as a registrar at Concord, this is many years ago, and it wasn't nearly as busy because all you had was like little flat houses around there. But now with all the high rises, the population is doubled. And it wasn't in the census data until the census happened.
And we're also seeing that in some of the sort of fringe regional areas where cost of living is lower and housing developments are going in, access to GP healthcare may be constrained, and or because of the financial challenges to access a private or a non-bulk billing GP, that we see people are using public health or emergency departments more pervasively to address perhaps not as urgent medical challenges.
And those things happen, but again, that's a general practice is unfortunately a federal problem, and so that's another humongous discussion for another day. Now we've talked about the difficulty in getting workforce, the collapse in, regional and rural health. And, I guess the other thing is that it's about the awards, right? Because the award are so antiquated and they're not fit for purpose. And it's getting to a stage where we want people to work a certain way, but the award does not support that, and therefore no one will work that way.
Correct.
And I'm going to be a bit controversial here. For instance, I know in the US, emergency physicians work night shifts, but in here, we don't do that. Even if you wanted to do that, it's impossible to do that with the award we have, isn't it?
Correct.
And I'm not saying we should do that, but I'm just saying that's one of the examples of how an award stops certain models of care or completely.
Totally. And let's play that thought experiment out. Let's say hypothetically, we embraced night shift and said, we're going to put emergency physicians on night shift.
Where are you going to get the people?
if we already are constrained from a supply and distribution problem, and we're already constrained and challenged to find enough emergency physicians, as an example,
to staff the daytime,
to staff the most urgent times with the most acuity and the most number of people, would it make sense to redeploy them to night shift? And so you may have senior coverage at night, but you lose the ability for that person to be present during the day when most of the emergency department work is being done. And so even if we turn that on in an award, hypothetically, if we all agreed to it, would as a department director, would you make the choice to redeploy someone to a night shift, which then perhaps means that they don't do as many day shifts? Or
but that's a zero sum game, right? Of taking staff from somewhere. You need to literally expand staff, and that's going to come at extra cost to the health system. Which, if we can't even talk about wage increase now, you're not going to get those extra people anyway, right?
Correct.
So I guess that was one of the terms in the new awards about putting people on for nights. So I was just like, where are you going to get those people if you're paying them such a shitty wage?
Yeah, well, that's again the challenge. And again, I can't speak on behalf of every staff specialist. Some people who do after hours because they stick around and they're sick patients and they need to look after them, they at least want to be paid for the hours they work. At a bare minimum. Get paid for the hours you work.
Because there's no overtime, right now.
Correct. There's no overtime.
There's already no penalties. There's no overtime. I think from the emergency physician perspective, at least, there is that extra loading you get because 50% of emergency staff specialist work is in the after hours.
So there is loading in the current award for emergency physician,
but not for anyone else.
But not for anyone else. And there are huge numbers of people in craft groups like anesthetics and intensive care. Even if you're going to talk about O&G service, if you're going to talk about after hours, pediatricians coming into hospitals in remote places because they know there's terribly unwell children and I may be the only person who's capable of looking after them. So there's many people who come in after hours out of the goodness of their heart or their goodwill. Going back to the paradigm that we're stuck in about the moral compass and why you pursue public health. And that means that we've tolerated the stagnation, despite the evolution of the way that we work. Of the stagnation of the award, that is the way that we're able to be valued.
And I think these sort of four problems are worth fighting for, resolving, because fundamentally it's going to impact on the profession, full stop. And so now let's get back to industrial action. Industrial action is, by definition, doing something that the employer doesn't want you to do, I guess, in a way.
So obviously there's, if you were going to be dichotomous about it, there would be one that's the work to rule approach, where you still come to work, but you, adjust the way that you work to, enforce your industrial will, to make it frustrating for your employer, to compel them to make a change on your behalf. And then the other approach is obviously constraining your labor so much that you don't come to work. And so those are the two sort of dichotomous approaches. And in the work to rule, in that realm, there are many options, or many available options, and the ones that may resonate the most with different craft groups and different sites will be different. And as I said before, it would be naive not to appreciate that nuance and make sure that if people felt strongly enough about the predicament that they're in, that we didn't empower them with options that they could demonstrate their
desire for
terror about the medium and long-term effects of the draft award, and their desire to see better outcomes.
I mean, because you've mentioned craft groups and different districts, we have to acknowledge that every specialty in medicine is quite unique and different. So a single solution just does not work across everyone. And that's the reality of things. And it doesn't work across the senior staff. It doesn't work across the junior staff, for instance. And they could do a variety of different things. And I guess we could talk a lot about that, but I'm sure the union will be sending out stuff for people to better understand what each kind of action actually represent
correct.
and mean. But I think we should talk about one particular staff sort of craft group, which is the psychiatrists.
Okay.
Because they're the first
by all means.
to take action, right? And what I understand is that there's 200 or so psychiatrists in New South Wales, staff specialist psychiatrists. I mean, this is not including the VMOs or the locums that fall under a different sort of category.
Yeah.
They felt strongly enough to not all of them, the majority of them put in resignation letters. And that is basically what you're saying, withholding supply of labor. Yeah.
So essentially this has been evolving for more than a year and a half with the colleges and the AMA and the union advocating to the ministers and the government about the workforce challenges, the workforce deficit. At the outset, there was about a 25% deficit in the workforce. By the time it's come to a head, there's about a 30% deficit in that staff specialist cohort. And the sentiment is that, again, the people who feel so strongly to work in public health appreciated that the system or what they were delivering was unsafe, and that morally they couldn't participate in that delivery anymore, that they felt they had to leave. These are such a dedicated, stalwart group of people who said, I can't do that anymore because it hurts me morally to be involved in a system that is jeopardizing safety because of the resourcing so much that this is the very last thing that I would think about doing, but I can't work here anymore.
Yeah. And that's a horrible decision you have to make, isn't it? Yeah. Coming from, as a medical profession. Yeah. They look after the worst people,
the most vulnerable people.
And the most vulnerable. Yeah.
And these people have dedicated their life to that in public health.
Yeah.
And they have not been treated well by the government. Yeah. And that is really sad.
And I'll just give a comparison because I know some of the numbers, is that, as a private psychiatrist, you could be easily making 3 to 4 times the amount of what you're getting as a staff specialist in the public system. Yeah. I mean, if you work to the same intensity, I guess.
Yep. So an even more disturbing issue, again, public-private, if people want to go into private, sure, by all means. But the even more disturbing issue was that the government has said, we would pay them to come back and work as VMOs or pay them to work as locums in the public. Yeah. We would pay them many more percentile than they're asking for. And you think, well, why would you send these people away to work in a different model and pay them more than they're even asking for? And what they would be giving up by moving to the VMO or locum model is what we talked about before. Yeah. They're giving up all clinical governance that sustains public health, all teaching and training and quality assurance and quality improvement and research. All of that stuff is what they would give up to move in this other model and be paid even more.
So why would they do that? I mean, because I know there's a number of psychiatrists that have actually formally quit and come back as a locum because New South Wales advertising for locum jobs, and they are paying nearly double, if not a bit more than what a staff specialist would be getting.
Yep, correct.
What's the game plan there?
It is unclear to me why the government would offer VMO and locum rates that are more than psychiatrists were asking for in the public system. Yeah. And ask them to give up the clinical governance, which sustains public health as we know it and is so progressive.
It's even more important in psychiatry because it's, you need a public psychiatry system. Otherwise, there'll be madness.
Well, I mean, it's almost akin to emergency. Those people are so vulnerable that do they even have the wherewithal or the insights to go to a private place?
Oh, no.
Probably not.
No. Yeah. That's his simple answer is no. Yeah.
And so it is mind-boggling that we're here having a conversation about that, where these people who have been so dedicated to public health in a progressive country have been essentially marched off the job, could come back and be paid double or more, but would give up the pillars of public health clinical governance.
Is this some press piece they're trying to win? Or, I mean, I have thought long and hard about this issue, and I just don't understand what the end game to that is.
You could speculate that the government may think if they were to give the laborers what they wanted, that they would appear weak.
Yeah. Okay.
Like if you were going to try to go,
so they want to hold on as long as possible, so they can,
so that everybody else doesn't come along and with their hand out. Yeah. But by doing that,
it's not very smart.
they're jeopardizing patients. And they're also, again, let's say, as you said, you're a public psychiatrist. You do have access to private. You do have access to come back and VMO or locum. When you put in your resignation, you probably didn't do that without considering how you would put food on the table and a roof over your head. And so you would have lined up some other ways to be employed.
Yeah.
And the longer this goes on, how much do you...
You're going to lose these people forever.
Correct. Like who wants to fight to be with their employer?
Yeah.
You want to have a battle to go to with the person who you want to work for?
It's like an abusive relationship, isn't it?
Yeah, I hadn't thought about it that way before.
Yeah. I think that's a great way to describe it.
Yeah, it is. It's terrifying to know the longer this goes on, more people will find a new way to sustain themselves and they will never return.
Yeah.
We've heard
they've seen the light.
We've heard, they've seen the light.
Yeah.
We've also heard about so many mental health units and whatnot with, bed closures. We've heard about patients languishing in emergency department for days or weeks.
Yeah.
And you think, that surely can't be what we would define as premier world-class healthcare.
Yeah. I've actually had a very interesting conversation with a psychiatry registrar the other night. And
where are they going to work next year?
Yeah. And they're saying it's like the whole system is falling apart. And I quote him, he said, New South Wales is becoming a failed state because we are destroying the healthcare system.
Yeah.
And I believe he was Korean. And he actually mentioned what's happening in Korea with all of the doctor walkouts in Korea.
Okay.
So in Korea, they've actually just like the whole segment of the medical system just walked out.
Right.
And they said, it's not our problem to uphold a broken system. And I guess that's where a lot of us are feeling right now.
There certainly are a lot of people who feel that way.
Yeah, amongst, in certain districts perhaps and in certain craft groups. Yeah.
Actually, I should say, I think everyone feels that way, but what they may be capable, because of their moral compass, what they may be capable of doing to demonstrate that will be different. But I imagine everyone feels that way.
Everyone feels that way. Yeah, I think that's the feel on the ground. And it pains me because, I've spent most of my professional life in the system.
And I've spent all of mine in New South Wales.
Yeah, I've got, you've got 2 years of it.
No. But it just, in terms of dedication to a system,
I know.
It's really sad to think about that the things that we know as fundamental to the ways of working, to teaching and training, to that part of me that again, if we talk about dopamine, it gives you a real satisfaction to help to teach somebody something that you know how to do, and you help them learn it, and they'll be able to deploy that and teach others. Yeah. And that will stay with them beyond my lifespan, beyond my career. That's a huge reward. Yeah. And to know that that may be in jeopardy, is terrifying.
Yeah, absolutely. So, I think you and I, we both feel for the system and what our colleagues and juniors are being put through. Yeah. And I'm sure there's lots of people that want to take action. But, historically, I think doctors have not been the best at union action. So if we felt strongly about this, what are the next steps?
So I'll go back to what you were first saying, which was you and I feel strongly about the system. And I think that's really important. The time that we spend with our colleagues and juniors at work is way more than we spend, if you were going to do the math, if you're not sleeping with our family.
Absolutely.
They become our family, and you teach and train them. And essentially they are part of, who you are professionally, but also personally. And so we need to help to advocate for them. And I just wanted to touch on the importance of the people in the system and how we look after them and how important they are to us.
Exactly. And that's why, I continue to work in the public system because, as a shout out to everyone who I work with, that you're my family. And,
exactly.
Absolutely.
And you spend, 40 hours with them a week. And again, not counting the time we're asleep. That's probably more than we spend with some of our family members. And so, and the reward that we get from helping them through their career and career progression is huge. So the question, we'll go back to the question you asked, which was, how can we, the people in the system, help to advocate in these challenging times? And I would simply say that anyone who is interested should reach out to the union, either by email or by phone, or by reaching out to organizers who will be in their districts and at their sites, to help them navigate the challenging times ahead.
Yeah, absolutely. And we're looking forward to some interesting times.
Yeah, I think we're looking forward to it being behind us and coming out the other side with positive outcomes for everyone, so that we can get back to caring for patients and looking after staff, and evolving the health system in the ways that we know are necessary. And it would be really nice if we didn't have to navigate the challenging times about the award and about the workforce deficits and the failures in the public health system in New South Wales. So
maybe I'm just someone who wants to watch some Brownstone and Fire.
Yeah. You can pull up a chair.
Grab my popcorn.
Yeah, exactly. Yeah.
Any final words, Nick?
Well, I would say thank you for having me today, and giving me the opportunity to talk to the people, at least from your point of view, who engage with the podcast. And I'm sure that we will be reaching out to you again, and appreciate all the time.
No problem. Yeah, thank you.
My pleasure.
This podcast is for educational and entertainment purposes only. The information and opinions shared are not intended as personal financial advice. The content presented should not be relied upon for making financial, investment, or other decisions. Listeners are strongly encouraged to seek the advice of qualified financial or legal professionals before making any financial decisions. While we aim to provide valuable and accurate information, we make no guarantees regarding the completeness or accuracy of the content. Any reliance on the information provided is done at your own risk.